Our next lecturer is Dr. Richard Nejat, who will speak on the computer-guided surgery, a CT-based advanced computer-guided in implant dentistry. He's a diplomate of the American Board of Periodontology. He lectures and is involved in clinical studies on the topic of 3D-guided implant dentistry and minimally invasive dental surgery. He has served several leadership roles in the AO as chair of the Online Continuing Education Committee and participant of the Academy of Osseointegration State of the Science Conference in 2006 and 2010. Dr. Nejat is a clinical assistant professor in the Department of Implant Dentistry and Periodontics at New York University, maintains a private practice in Manhattan and Nutley, New Jersey, with an emphasis in 3D-guided implant dentistry and minimally invasive dental surgery. Dr. Nejat.
Thank you, Dr. Rosenberg. And thank you, the organizing committee, for selecting me to speak on this topic with you today. My presentation today will be about introducing a new protocol using 3D imaging to facilitate immediate function with extractions in an evolving, efficient, and aesthetic way. Important if we're going to discuss immediate function, we need to discuss the progression of where we started to where we are now. Where initially, about 20 years ago, Dr. Schnittman presented the use of 3 implants to support a full arch conversion prosthesis. And a conversion prosthesis is basically a denture, an immediate denture that is relined over the implant abutments. Then we progressed in 1997 with Tarnow's work of loading alternate implants to support this conversion prosthesis. And then others, including Balshi, started using all the implants as long as they followed a good stability and used that to support a conversion prosthesis. We've also progressed with the use of our radiographic templates. They started off initially using just some gutta percha, and then we started using some barium sulfate and taking impressions of our dentures and then using them on our scans to get some imaging. But that introduced error, where we had to now take an impression and now have something that has introduced with error, our radiographic template with barium, where now we have currently available taking a patient's well-fitting aesthetic denture and then getting a much more diagnostic image that can be used in our planning process. As of other things have evolved with our templates, we've now evolved with our surgical templates. We initially had to use multiple templates for the drilling sequence. And we also had to stabilize these drilled templates with our fingers. To now, we have the ability to have one template with anchor pins that will allow us to have the surgical template stabilized and use drill sleeves to go in sequence to be able to place our implants through the surgical template. The manufacturers have also produced the armamentarium necessary to produce a master model even before the surgery is done. So how accurate is guided surgery? There was a recent article by Schneider that reviewed 8 articles. And what he presented in his research, or in his article, that there was a mean angular deviation of about 5 degrees. And there was a deficiency of about 1 millimeter with the placement of the implant. So what is the source of error? It's very important through this whole process of whenever we do guided surgery that we eliminate our error by following certain steps and doing things in sequence, because the error is amplified through the whole process of this treatment. So that the first step is our radiographic template. It must be fit, and it must be fit in a repeatable manner. The surgical template also needs to be fit, and it has to be fit in a repeatable manner that is matching the same way as a radiographic template was seated. Our stereolithic templates must be also manufactured accurately, and our surgical instrumentations go through wear with time. We need to observe any changes of wear. And sequencing and implant positioning of our implants is a critical step also. So how do we determine the stereolithic material template's margins? Now, our radiographic templates are essentially essential in this whole process. So if our radiographic template, we need to identify the margin of it so that when it's manufactured via stereolithography, we have the surface of the radiographic template very clear and very accurate. The image to your left here shows a low ISO value. That's when we have too much information. When we have a high ISO value, we're not having enough information, so the surface of our stereolithic template will be off. And if we look closely here of the margin of the acrylic, we're not really sure where it actually ends. So it's critical that we be able to identify that margin. Now, Stumple also found these same findings, and he presented this observation where he took a patient's denture and he duplicated via stereolithography. And then he used a putty index, and he saw that the putty index didn't match, or the radiographic template didn't match the putty index. And then the same he also saw on the surface side of the radiographic template, or the duplicate of that denture. So there's some error here. So the manufacturers have been listening, and they've developed some calibration tools that are essential for guided surgery. This calibration disc helps calibrate our scanners to get the proper ISO value for the acrylics we use for our radiographic templates. This will allow us to have more accurate stereolithography of our surgical templates. So the workflow. So now I'm going to start describing the protocol that I've developed to basically explain how we're going to do this. How we're going to take someone who has the need for immediate extractions, guided surgery, and immediate placement of implants. So this process is very much evolving. We're going to use all the technology that we have been introduced to us, and we're going to make it much more efficient for the clinician and the patient, and increase our aesthetics to the highest level that we can available to us at this time. So here's our typical patient. The patient comes in, they're not very happy with their smile, they can't even smile if they wanted to, their teeth are mobile, they're not really able to function. We want to start off with very good impressions. The impressions are equivalent to if you're going to do an immediate denture. You need to capture the soft tissue and the vestibular area as best as we can. Then we're going to mount our case using Facebow and an articulator so that now we can go to the next phase and reduce the teeth. We're going to reduce the teeth the way we think it's going to look like after the teeth are extracted during the surgery. We want to really try to mimic how the tissue is going to look. Now, we're going to set our teeth up, and when I do these types of cases, I like to keep a tooth, or as many teeth as we can, to help the radiographic template be positioned properly. Now, this is our setup. We want to create an ideal setup. So this is our setup, and it gets converted into a clear denture. Then the denture is going to be broken up into many pieces. We have the tooth portion, and that's the base portion you see now. And then we want the laboratory to create basically a clip that's going to help support the anterior portion, or the flange area of this radiographic template. And then we're going to use something that all of our kids have, a Lego piece. And that Lego piece is very inexpensive and very accurate. And it's going to help put everything back together. Then we're going to use a round burr and prepare our radiographic markers using Cavit or gutta percha. And we want to make sure it's only on the base portion, including the flange area. So now that we have our radiographic template, our patient's going to be ready. We want to try it in our patient's mouth to make sure they're ready to have this fit prior to the CT scan. So we reassemble this radiographic template in the patient's mouth. And a very important step is placing our putty index. The putty index is fit to make sure the soft tissue and the guide is everything is positioned in a repeatable manner, so it's well fit. Now we're ready for our CT scan. I'm going to repeat the same step. We're going to put the guide back in, make sure it's seating properly. All the clips should fit precisely. We position our putty index in the patient's mouth, and the patient goes through the first scan. So this scan is capturing the first part of the radiographic template. Then our second scan is we reassemble the radiographic template, putting all three pieces together. And then we're going to do a second scan of the full radiographic template. And that template will now the CT scan will capture the data from that template. Now the DICOM data, there's two sets of DICOM data, are important to our software. And we're going to get the surface of the bone, and we're also going to get the surface of the teeth. And now we have the surface of our radiographic template, which we'll call our 3D wax-up. Now we can plan and position our implants to match the position of these future teeth in the best prosthetic and aesthetic location. And we can plan it in a great fashion, where we can even design and put our virtual teeth in there if we want, and match it up to that radiographic setup. And now we can even do an optical scan of the patient's of their model to capture the soft tissue, capture the margins of the soft tissue, and be able to create the proper emergence profile of our implants to match the hard tissue and the soft tissue now. Now we're at the 3D printing phase. Now we have to fabricate our stereolithic guide. So we take our plan, and that plan gets converted into a CAD file. That CAD file, which you see right now, is now using stereolithography, is sent to the manufacturer, and using a vat of acrylic, they cure that 3D object into one. And then the titanium sleeves are fit into it and glued inside, and they're sent to us to now go to the laboratory phase. And in the laboratory, what we're going to do is seat that surgical template exactly the same way as the radiographic template was seated. We'll put our anchor pins in to keep it stabilized and go through another critical step, our putty index, to position that surgical guide exactly the same way so it's repeatable at the time of surgery. Now we use the armamentarium developed by the manufacturers to seat analogs into our master model, kind of using an ultracast technique. So our analogs are all set into the model, and we position our abutments that we planned in the 3D plan, and then put in some conical cylinders. Those cylinders are placed, a cast framework is fabricated beforehand, and then the bridge is processed. You'll notice that the cylinders are not processed into the bridge. Now with the surgery, the most important step is atraumatic removal of the teeth and preservation of the soft tissue and the hard tissue. We seat a surgical template in the patient's mouth. We place our putty index, surgical putty index, and now we're going to stabilize that surgical guide using our horizontal anchor pins. Once the guide is stabilized, we're going to remove that index, and we're going to start preparing our osteotomies. Very important when you're preparing the osteotomies is to get the feel of the bone when you're drilling, because the drilling protocol will change from patient to patient, where it might even include the tapping of the sites, especially when longer implants are being placed. Now the implants are placed in a manner to help reduce any movement or any pushing of the guide, so that the guide's position is always kept stable. Now we remove our fixture mounts and our anchor pins, and then typically in these types of cases we'll have a remaining tooth that needs to be extracted. So once the surgery is completed, we're ready for the immediate prosthetic phase. The abutments are placed, our cylinders are placed, and our bridge is placed into the patient's mouth. We use some long screws to help lock out any acrylic which is injected around those cylinders, so that we have a clear screw access hole. Replace our long screws with some short prosthetic screws, and now we're ready to start managing the patient's occlusion. very important step, and probably the most important step in this whole process, is the patient's occlusion. We've actually added to our protocol the use of a digital analysis of the patient's occlusion, utilizing a system that helps us quantify the patient's forces of occlusion in various areas of their bite to make sure it's properly balanced. Once the occlusion has been calibrated, we're going to take off the prosthesis, and we're going to fill any voids that have been left over and polish any areas that we have any flash of material. The bridge is then screwed back into the patient's mouth, the anesthetic is worn off, and we always have a happy patient at the end of this type of procedure. They cannot believe how beautiful their smiles are, how we were able to address all these aesthetic concerns without any try-ins physically in their mouth. So Cantoni, 2 years ago, published a wonderful paper presenting this concept of a multi-piece radiographic template to allow us to place implants into extraction sockets. What I've done is change the protocol slightly where we're able to use a multi-piece radiographic template where the base separates itself apart, and we use these Lego pieces or different markers to make sure it's adapted back together. It allows for a tighter fit. It also allows for the template to be fit over flared teeth. So what I'd like to do now is to go over some cases. Cases specifically are the first case, which uses a hybrid design where it's tooth and tissue supported. The next case will be only tissue supported, and the last case will be both jaws, which is tissue supported in the upper jaw and tooth only supported in the lower jaw. So this is how the patient presented to us. A very unaesthetic smile. He didn't know how to smile and didn't want to smile. He had some periodontitis, and the first step of this whole process is analyzing the patient's smile. So when we analyze the patient's smile, we look at their midline, and we want to look and see how there are any cants. So if we take a closer look at his smile, we can see there's many discrepancies here. We have pathologic migration of the teeth, we have some midline deviations, we have tooth size discrepancies, and there's issues with the lower teeth also. So what we've done is we did our radiographic template, we scanned it in, there's our plan. And what you see here in red is the patient's existing, and you see in teal is the patient's new prosthesis, what we're planning on doing and how we planned everything together. So we've addressed these concerns as tooth length, and we've also adjusted, before we ever started this whole process, was adjusting his lower teeth too to help make space for the proper smile line. So now we can superimpose that new smile into the patient's existing smile. What we have now is his plan. We have one tilted implant number 13 to avoid a sinus graft or angular implant, and then all the other implants are placed into extraction sockets. So we've taken great care of removing these teeth atraumatically and left tooth number 3 to help support our surgical template, as you can see, and then we placed our 6 implants. The 6 implants were placed, 5 of them were loaded. One of them, tooth number 11, the root was about 16 millimeters long, and we weren't able to get as good a stability, so we used 5 implants. You'll note here our angled multi-unit abutment with a jig to help reposition it in the same manner. This is what the patient left with after surgery. This is 1 week post-op healing, where you can see we addressed those aesthetic concerns for the patient. So we went from the left to the right, and you can see how we were able to basically take that planned case and take from a guide and get it to reality within just a few hours. What's really remarkable is his full face smile. You can just see how he's changed his whole, just within a few days, how he's changed his smile. He all of a sudden got a smile. His confidence has changed very quickly too. The next case is someone with a high smile line with only 4 teeth that need to be extracted. Okay? We had a decision here. Do we reduce the bone or do we preserve the bone? Well, he had some pretty good bone, and the bone was it was even. So what we decided was not to reduce it and to use a tissue-supported guide, place 8 implants. We only loaded 6 of them, and we did site preservation where we extracted the teeth. We have our jigs fabricated here to help position the implants in the best location, as Dr. Weber discussed now. We have to always look at where we want it to be prosthetically. So you can see here that the implants are all placed exactly where we want it to be with an extraction case. And then he leaves, this is immediately after surgery, this is his prosthesis that he leaves with. So he started off here, this is immediately after surgery, this is 1 week post-op healing, and you see up close how the papilla is starting to form into the embrasure spaces. So someone who's embarrassed to smile because he has a horrible prosthesis, now with this high smile line can even have his own soft tissue to replace his smile. And our final case, which involves both jaws. This case is a mess. She's got teeth, she's got every problem you probably can have in dentistry, okay? And we look at her x-rays, she's not like she didn't go to the dentist. She went to the dentist, but I think she told the dentist what she wanted. So she has already an existing implant, number 7. And so we're going to design this case to work with that implant. And we're going to do this in stages. So we're going to do our smile analysis with the patient. And we're going to see that she's got the typical midline issue. She's got the teeth are all over the place. And we're going to look at this closer in her smile. And then we're going to do her setup. We're going to do a radiographic diagnostic setup. And we want to make sure what we did on the radiographic template matches up exactly with what our goals are prosthetically and aesthetically for the patient. So here's our plan. We're going to plan to place 2 implants on a tilted or angular basis, and then 3 remaining implants into extraction sockets. And we're going to use number 7, that implant which is already there, that's integrated. But we put it into the plan so the lab can see it. The laboratory knows that we're going to have an implant in that area. So prior to surgery, we extract the teeth as atraumatically possible, put our healing abutment in, the site number 7. Surgical template is positioned well, implants are placed. We take the guide off. This is the tissue, how it looks. This is our pre-manufactured master model so that we can have this bridge pre-made. And this is what the patient looks like right before surgery. So we did a frenectomy up here, and then we put the bridge in, and then we adjust the occlusion on the lower teeth to fit this new upper prosthesis. 1 week post-op healing, the tissue responds very well to it, and her smile has also been addressed. But she's not done. She needs a lower jaw now. So the lower jaw is a little bit more complicated. We don't have a palate on the lower jaw. So we don't have the ability to get that guide to sit accurately unless we use teeth. So we select 3 teeth to help tripod the surgical template exactly in the same position as we planned in the planning process. We extract the teeth except those 3 teeth, and then we seat our surgical template over those teeth. And we have inspection windows made to make sure that it's seated down properly. The implants are placed. It's 4 in this particular case, 2 in the back that are angular. And that's what it looks like after we take the guide off. We did a little flap over here just to keep the attached tissue where we need it. And now we're ready to put the prosthesis in. So the prosthesis is fitted, the occlusion is adjusted, and this is what the patient leaves with that day. This is 1 week post-op healing, and this is the patient's smile. So we took someone who was really a mess, and in a few days, and just literally in a few hours, she leaves with something like that, and be able to place implants in not just in the mouth, but in an accurate fashion that's going to give us a beautiful prosthesis. So we took a patient who really didn't really feel she could be social, but now she feels that she can function not just with her friends, but also be able to function with eating and speaking properly. So what do you do when you have a high uneven smile? Okay? These types of cases follow a different type of protocol. We need to always analyze the patient's smile. Again, with Dr. Weber, he emphasized in his lecture. The smile is critical. And we have to create the margins of our prosthesis to be out of that smile zone. So what's going to be indicated is alveolarplasty. This is when it's indicated. So we've compiled our cases over the past 4 years into a publication that we're preparing that utilizes this protocol of guided surgery with a multi-piece radiographic template in conjunction with immediate load with extractions. And what we have is a total of 162 implants placed, and we had about 115 placed into extraction sockets. And we had 43 placed into healed sites with only 7 implants that did not integrate. Our cases were 16 in the maxilla, 13 in the mandible, with almost an even distribution male to female, using different systems out there. Our results. We had a 96% success rate with 71% of our implants into extraction sites, with no prosthetic failures through the whole process. So what are the advantages of a multi-piece radiographic template? Precise implant osteotomy preparation. By having this precise implant osteotomy preparation, we're able to have a very accurate hole so the implants can go in tighter. Guided surgery into fresh extraction sockets. That's something that's not really been popular and something that now we can do. I think we have a better way of doing it now with guided surgery. Better, stronger, immediate load provisionals. These are provisionals that have a cast framework in them. These are not converted dentures. No same-day lab appointment needed, so this prosthesis can be pre-manufactured and the patient doesn't have to wait or come back the next day to put your bridge in. The chair time is less. Everything is pre-planned. It's a matter of just making sure we just do it sequentially and follow our steps so we don't have any error amplified through the process. It's a better diagnostic tool for 3D planning. You saw how we're able to take these horrible smiles and turn them into these, I think, fairly aesthetic smiles without even trying. It's using the technologies that are available to us right now. And most of all, I think, we can preserve the hard and soft tissue when it's indicated, obviously. It can also be used to plan angled implants, including zygoma in a semi-guided process, and pterygoid implants when there's not a lot of bone. But there's always complications to these types of things, and we have to be all aware of these complications so that we can avoid them or be aware of what we should do when they do occur. So there's guide fractures. The surgical guide can break. Again, you have to design that when you're designing a radiographic template to make it thick enough so they don't break. During the surgery, the anesthesia can wear off. Try to use a long-lasting anesthetic or sedate the patient. The guides need to be seated properly. If it's poorly seated, everything's not going to fit. The bridge isn't going to fit. The occlusion is going to be way off. Lack of intraoral space for your armamentarium. Test it before you start the surgery, before you even take the case on. The teeth can shear off the provisional bridge. So when you're planning these cases, you need to make sure you plan the implants in the proper location so that these cylinders are not too close to the facial aspect of the teeth. Because if we position the implants properly, our prosthesis will be stronger and less likely to have these complications. So that's a big benefit. And sometimes the provisional doesn't fit, and that's usually because we have an error that's amplified through the whole process. Conclusions. Appropriate patient selection. Not every patient is a candidate for this type of thing, but a lot of patients are. Surgical experience precedes everything here. You need to know what you're doing surgically before you can start doing this stuff with guided surgery. As we discussed earlier, the smile line. The smile line is everything. If you don't analyze a patient's smile, you're going to have errors. You're going to have teeth that don't look right. You're going to have your margin, you're going to have pink materials exposed and showing the patient's existing gingiva, and it doesn't really match. You have to make sure you prep your osteotomies properly. These osteotomies, even though it's a different feel, Dr. Palazzi yesterday presented, guided surgery, and he mentioned that it's a different feel. It is a different feel, but you can still feel. It's not blind. You can tell that you have soft bone, hard bone, different types of bone, so you got to prepare it properly. Use taps when indicated, when it is dense, because if you don't use a tap, that implant's going to move your guide distally or mesially, or even deeper. You have to have an alternate plan when you do these types of cases. You can't just go in saying, okay, that's it, I'm done. And the biggest thing is you can't alter the plan with a template in the patient's mouth. Obviously, you're going to have to take it out if you need to alter it and make any changes. Well, we've really come a long way with technologies. We started off with an iPod. We got the iPhone. And now we got the iPad. But you always need iGuide. And I was trained at Stony Brook University over 10 years ago, and Dr. Vince Iacona was my chairman, and he's always talked about iGuide. And essentially, it's something that we can't take for granted. It's something we're born with. And when you do these types of cases, if you don't use your eye guide, ultimately you're really blind. And we can't be blind. Even though it's guided surgery, we still have to use our eyes when we do these types of cases. Thank you for your attention.